Well, I think we have to talk about what infertility is. I mean, it's the inability to achieve a pregnancy technically within a year. Other people define it as within 2 years. So really, the important thing is not what an insurance company or a government might define it as, or even the World Health Organization, who happens to define it as 2 years, but what the couple defines it as. And it really changes for individual couples. You have to individualize the definition. For instance, for a young couple who's 20 years old and trying to get pregnant, you're not going to get worried if they don't get pregnant in 1 month or 2 months or 3 months. But after 6 months, you would expect most young couples to have been successful already. So you already start identifying people who might have a problem. But for the young couple who's 20, it's probably not a big deal if you don't make the diagnosis for another 6 months, because their potential will still be there. For an older couple over the age of 38 or 40, the fertility changes so quickly that losing that extra 6 months is a big deal. And so for a couple who's, say, 40 and trying for 4 months, they might start wanting to wonder what's going on and having some testing done to be sure they're not missing the boat. Because if they wait for a year or 2 years, you're going to have a problem. As we think about the couple who comes to us with an inability to get pregnant in the time that they hoped to conceive, our first step is to evaluate them and see if their anxieties are well founded. And our second step is to begin to reassure them and look at the different parts that come into, might be responsible for their infertility. So it's like any system. In order to make a baby, we need eggs, we need sperm, and we need a way for the sperm and the eggs to come together. And it's fairly easy to begin that evaluation with a few simple tests. I think that we can cover 80 to 90% of the issues in the first few weeks after we first meet the couple by doing some blood tests to test for ovarian function, doing a semen analysis to test that the husband is okay, and then ultimately testing to see if there are problems with the fallopian tubes or not. And I think all those things can be done relatively quickly. The other test they do that's part of the basic workup is called a hysterosalpingogram. The hysterosalpingogram, which we abbreviate HSG because nobody can say hysterosalpingogram, is looking at the shape of the inside of the uterus and whether the tubes are open or not. Many centers have required women to come back on the second or third day of their cycle for FSH and estradiol, and those are still very important tests. But in recent years, we've increasingly been using a new determination known as anti-Müllerian hormone, otherwise abbreviated AMH. Now, AMH is an interesting test because you don't have to do it on a specific day of the cycle. There may be some slight changes as a woman goes through her cycle, but not enough to really influence greatly. We can draw a blood test on a woman the first day she comes in for her first visit. We'll get the result back within a week or so. That is highly predictive of her ovarian potential. So we'll already know within a few days after her first visit where she stands with regard to her ovarian function. There's this class of so-called unexplained infertility, and we have some very strong feelings about that here at CHR. It's true that if you do that basic testing, you can account for 80 to 90% of the causes of delay in conception, but there may be other things that are normally kind of put in this garbage pail diagnosis of unexplained infertility that many clinics don't look for. There can be women who have subtle changes in the way their ovaries function that may explain their inability to conceive in a timely manner that aren't picked up by the routine kind of testing that other fertility centers tend to do. In a similar way, there can be problems with the embryos or with implantation, secondary to immune factors that we can pick up by some of the extensive immunologic testing that we do here. So I'd say that at the end of the day, whereas many centers will have 15 to 20% of people they'll consider to have unexplained infertility, there are very few people that walk away without a diagnosis at CHR. And it's important, because if you don't make a diagnosis, you can't approach a specific treatment. And we like to tailor our treatments to the individual patients based on what we know about them and the diagnoses that we see. There could be somebody who, by traditional criteria, the old World Health Organization criteria for semen analysis, had a normal semen analysis, but when you look at it carefully, looking at strict morphology, there may be less than the required number of perfect sperm that would explain a delay in conception. Similarly, there may be a woman who has FSH that's higher than we would expect for her age, or AMH that's already low. We also have age criteria for AMH that others would identify as being close to the normal range, but we would identify as having an ovarian problem. In each of those cases, we can tailor our approach to increase their chances of success. Well, it will always be true that the most effective thing we can do is in vitro fertilization. If you think of this as a stepwise process, IVF and all the related procedures that are IVF will always be the most effective way to help people get pregnant in the shortest period of time. But it doesn't mean it's the only way. So that a young couple with open tubes who has time could go through a few cycles of what might be a less effective, but perhaps less costly, perhaps somewhat fewer procedures way of achieving their goal. And what we've done over time, over the years, is a procedure known as intrauterine insemination. There's really a couple of parts to intrauterine insemination. We originally thought of IUI as a way of addressing a couple with normal ovarian function and low sperm count. And the notion was that if we took that semen specimen, which maybe had, let's say it had 20% of the normal count, and we then concentrated the sperm into a very small volume, we could put a larger dose of sperm into the uterus. What ovulation induction does is helping the woman to produce more eggs. Now, we used to use ovulation induction just for women who didn't ovulate, and there certainly are still a number of those, and they are helped by taking fertility meds to ovulate. But the more common usage today in infertility is to take a woman who normally cycles every month and produces one egg and help her to produce multiple eggs. By producing multiple eggs, it's like presenting multiple targets, multiple opportunities for the sperm. And so you increase the likelihood that some sperm and some egg are going to find each other, just because there are more numbers. So if we do the intrauterine insemination that we mentioned before, which increases the dose of sperm into the female system, and ovulation induction, which increases the number of eggs, we increase the likelihood that some egg and some sperm will get together and thereby increase the chances of pregnancy. So IVF, as I started out by saying, will always be the most effective way, but there are other things